So this is case 4. Is it just to remind you, lest we forget? We nephrologists don't do much in this area. So I thought I'll show my case, which happened only a few days ago. A diabetic patient, 25 years, hypertension 5 years, had diabetic retinopathy, renal failure detected during COVID. And he was started on CAPD and discontinued after 3 months. And after that, he was going without dialysis. So probably it was AKA or acute on CKD. And now in April, he is presented with anorexia and they found uremic. He was initiated again on dialysis outside. He was on twice weekly dialysis. And native kidney urine output was only 300 ml or less. But he was repeatedly getting breathlessness and recurrent pulmonary edemas. Initially, they managed him as viral pneumonia and so all sorts of things outside. And after coming to our center in Kaveri here, they realized that every day, morning I go, he would have been intubated because of breathlessness, evening extubated, and a dialysis given. So they started telling every day dialysis helps this man. He keeps going without breathlessness and his sensorium improves with dialysis. So at that time, I thought, why not consider renal artery stenosis? This is, typical CKD for several years. So what is the point in doing things? Then cardiologist wanted a CAG to see whether the pulmonary edema is due to that. So he was taken for angio. So these were the likely causes we thought of. And his renal Doppler, we could not, he was in the ICU always, sick every day. So we considered coronary artery disease, possible triple vessel disease, and bilateral renal artery stenosis. So, yeah. So, so this is the angiogram. You see that he has bilateral renal artery stenosis, nearly 90%, both on right and left. And his vasculature was not really great. So we knew that this may not help his renal failure. At least the flash pulmonary edemas we could get away with. And so left side, you see it is a discrete stenosis, but the right side, it was funny, the stenosis is here. And the flow was very clumsy even otherwise. See, as though some fresh event has occurred, some thrombus or something in that dilated artery. And we quickly went on to stent the left side. We put in the guide wire, and I'm not going to the details of this. And it was pretty easy. Guide wire went because it was a renal artery which was going in a very convenient angle to the aorta. So it, we stented the left, and again the right side we had some difficulty because of putting in the PTCA wire. Yeah, so we succeeded, and now both sides were stented successfully, and I wanted to show you the. Okay. Anyway, the vasculature improved significantly, but didn't give me hopes that he would improve from renal failure. And the coronaries, there was only single vessel disease, and this is the stenosis they say is a significant stenosis. You saw the renal arteries where we want such 90% stenosis to intervene, but this is the coronary stenosis they saw, and they wanted and they put in a stent. So post procedure, now it is nearly 1 week or 10 days now. He has had no episodes of flash pulmonary edema. His BP is stable. His urine output is increasing now. Yesterday it was 1000 ml, and his creatinine has remained stable around 6. So that was something very surprising and unexpected for me, because an established case of CKD. But one thing we could achieve, no more pulmonary edemas, but I don't know how much more creatinine will come down, unlikely. But I think, so I was happy with the results. So it is just to remind us all that it is our job to identify and treat bilateral renal artery stenosis or single site renal artery stenosis. We can't expect others to come with the diagnosis and treat. That's all, friends. This is besides the usual stuff we talk about, and definitely Hardik would have things to say about this. He might have had instances, but because coming to renal artery stenosis intervention, the general impression is there is no use. Either you are very late and doing early has no use, and things like that. But if you are meticulous, if you choose your cases, definitely you can achieve something good out of it, either preventing recurrent pulmonary edemas, or in this case, he might go home without dialysis. His renal failure will not come back to normal. So that is the case I wanted to show before we go on to the next case. Anybody want to comment on this?
Sir, am I audible?
Yes.
So we are in process of compiling data of last 5 years of renal artery stenting. So we have diagnosed more than 500 renal artery stenosis. We have done renal angiographies for more than 250 patients, and we have actually stented only 150 patients. And out of them, 6 patients were on dialysis for more than 1 month, and 5 of them actually began dialysis independent at least for a year. So as you showed, sir, if patient has flash pulmonary edema, definitely stenting will help, and at least his blood pressure control will improve. And even 6 months to 1 year of dialysis is precious. So we are right now in the process of compiling and assessing the data, and hopefully will present it soon. So
I think the learning point for me is we should have a lesser threshold for doing a renal artery angiogram, sir, at least.
Yes. Yeah.
yes, here, sir, could we have done CT renal angio before, sir? Already he was dialysis dependent. And once he was stable, could we have done CT angio here, sir?
Yeah, that is what I routinely do. If not CT angio, I do MR angio. But this case, he was sick and the cardiologists were itching to take for coronary angios. Then I said,
They anyway were taking.
yeah, we will
Okay.
prefer femoral puncture rather than radial, and let me look at the renal arteries. So,
Okay.
and the renal Doppler may not be typical Parvus status in this case, even if I had done. Just to remind people, so we don't forget about renal artery stenosis, which is potentially treatable, at least in some cases.